Okay, well, welcome everybody. I'm happy to finish up today's talks, a couple of great talks. My hope is to hopefully leave with some provocative thoughts. And today I'm going to talk specifically about vascular access in the elderly and frail, making the right AV access choice for your patient. All right. So today's learning objectives, and hopefully by the end of my talk, you will recognize the origins of our AV fistula-centric vascular access practice, as well as be able to appraise the recommendation of fistula first in an aging and frail dialysis population. And then finally, identify the importance of shared decision-making and patient preferences in vascular access and care for the elderly. So who are the elderly and frail? I actually need to move this here. There we go. When I Googled elderly, this is what I found, this definition, and I thought it was compelling. As well, the majority of studies that I did review also attached a certain age, and the age tended to be anywhere from 65 to 67. As far as who is frail, this is a definition that I found referred to often, and so I've included it here. And I think it's important to remember that more than 75% of patients receiving dialysis for kidney failure who are older than 60 do meet this criteria for frailty. And frailty is associated with more than a twofold increase in one-year mortality for patients receiving maintenance dialysis. So I wanted to frame our conversation today by sharing the statistics, or vascular access statistics at least, of the patients who dialyze with us here at the Seattle VA in the renal dialysis unit. And this is data as of December of 2022. And I'm for note, I am the medical director. So this is something that I look at quite a bit. So I've listed the different vascular access types and combinations, as well as the number in each category, the age range, and then the average age based on the numbers. And then I also attempted, with that definition that I just shared, to quantify, at least by my own interpretation, the number of frail patients that we have. And I think you can see by the access type, the majority of our patients have either a fistula or a graft. The youngest patient is 51, oldest is 89. And it's interesting, though, that either the majority of our patients either have both age, or are both elderly by age and frail, or at least either they have both or at least one. And I think I can only really think of one or two which doesn't fit either definition. With the asterisks here, I've sort of explained some of the number of among our catheter-only patients, sort of reasons why they don't have a permanent access. And I just wanted to focus on the three that refused. And these folks have done so mainly out of concerns about hand dexterity, arm strength, or just overall concerns about additional surgeries, of which they've already had many. So where does the RDU stand with our statistics? So this here is the VA comprehensive measures for vascular access, and they have set a targeted goal for number of patients with AV fistula at 64.35%, as well as a goal of 11.05, greater than or equal to 64%, and then also a goal of catheters greater than 90 days for 11.09% or less. So I think it's obvious that we are nowhere near these goals. And honestly, we're never going to get there with our current patient panel. And at a recent national meeting, we were reassured by our deputy national director, Paul Pileski, that these measures are not meant to be punitive, that was his quote, but rather best practices. But of course, I have to admit that it does feel punitive in that at least monthly, I have to report to various groups about what we are doing to meet these standards and how we plan to do better. Now, outside of the VA, we have the ESR, there's the ESRD QAPI program. And this program does link 2% of payment to the dialysis facility for Medicare patients based on the performance on a totality of quality measures, of which 2 are the ones that we've listed here. Now, one thing I will say about the ESRD Quality Incentive Program is that it does modify the denominator. So not all patients that you might be dialyzing are included, and those are pediatric patients, those with limited life expectancy, i.e., for example, in hospice, metastatic cancer, end-stage liver disease, and a coma or anoxic brain injury. So those are not considered part of your total. Now, the VA does not do that. All right. So where did our love of the fistula begin? So this is a timeline, and we can say things began in the 60s. And in 1960, as we all know, the first AV fistula was invented by Scribner and his colleagues. And for the first time, long-term hemodialysis was now possible via a removable U-shaped Teflon shunt connecting an artery and a vein in the arm of a patient. The first autologous AV fistula was then developed and used as a reliable form of vascular access in 1966 by Brice and Sumino. And in the 70s, we saw an expansion of patient eligibility and the development of other technologies such as the AV graft, and both those helped to really expand the ESRD population or program. And in the mid 80s, permanent catheters became more and more common as a way of prolonging temporary access prior to permanent access placement. And by the 90s, this cumulative effect was an overall reduction in the use of AV fistulas and an increase in graft and catheter use. And this was associated with increased costs, presumably due to access-related complications. And in an effort to improve outcomes, the National Kidney Foundation published the first of the KDOQI clinical practice guidelines on vascular access in 1997. And in the following year, CMS developed clinical measures based on these guidelines to monitor vascular access complications in an effort to improve patient care and reduce costs. And by 2002, the total ESRD program cost reached $17 billion, and $200 million of which was for vascular access. And that was a 4-fold increase since the early 90s. And then finally, in 2003, the CMS and ESRD networks jointly formed and implemented a national vascular access improvement initiative that was called the Fistula First Initiative. And this was an effort to increase the number of fistulas. All right, so the Fistula First program promoted the AV fistula as the first choice and the gold standard for AV access. And this was based on the evidence that they looked at, they felt that they lasted longer, needed less work, and were associated with lower rates of infections and hospitalizations as well as death. So at the time of the fistula, going too fast. At the time of the fistula first launch in 2003, there were only 32% of patients had a functional or had an AV fistula compared to 40% grafts and 28% catheters. And the primary goal was to reach or exceed the goal set in the KDOQI guidelines of 40% prevalent patients by 2005. And they did very well and exceeded their goals. And this goal, therefore, was increased to 66% in 2009, which is approximately where our goals are today. All right, so is a fistula the best access for my patient? Well, I think it's important to review some of the challenges that we see not only in the elderly and frail patients, but in really all patients with fistula. And first of all, the supporting data used to justify the Fistula First was observational, but I think more importantly, it was based on a younger and pre-Fistula First, highly selected patient population and may not really apply to my patients or even the majority of patients that are recommended to get an AV fistula today. Now, as we already noted, the Fistula First campaign was very successful at increasing the number of fistulas, but the functional fistula tended to not be immediate. And there certainly was an increase in delays in maturation, as well as failures to mature, which required more procedures and really an unplanned increase, or at least stability, not a decline in the use of catheters. And this actually brought about a rebranding of the fistula first to the fistula first and catheter last in 2015, I believe. And the efforts were then not only focused on increasing the numbers of fistulas, but also avoiding the extended use of catheters. But I think finally, and very important to our patients, to my patients, is that there is this competing risk of death. And my patients may not survive long enough to reap the benefits of an AV fistula that is taking longer to mature, if it's even going to mature. So this is data from the latest USRDS annual data report from 2022 showing incidence and prevalence of ESRD on all modalities by age. The dialysis population overall is aging, and not just at the VA. Now, not shown here is that 83% of incident ESRD starts start on hemodialysis, and over 50% of prevalent are on hemo. So on the left here, we have the incidence, age adjusted from over the decade 2000, sorry, to 2020, as listed by age. And you can see here that incident patients are highest, the highest numbers are in those that we can classify as elderly. On the right is prevalence, again by age over the same period. And you can see that the prevalence among older individuals was consistently higher as compared to younger. And also the rate of increase of prevalence was also greatest in elderly. So let's look at some data that's more relevant to our patients. Now, this is a retrospective study, observational, that took Medicare claims data from 2006 to 2011 and consisted of over 16,000 patients with ESRD on hemodialysis, 66 years of age and older. You can see that 74% got a fistula, and they looked at the incidence of repeat fistula graft creation and tunnel catheter placements over a 12-month period. Right, so here's a graft, and you can see that, so here are the different combinations and the percentages, and in terms of a repeat fistula or graft in the incident fistula in the blue or incidence graft in the red, there was a statistical difference of higher rates among the incident fistula, as well as in the incident fistula group had higher rates of a repeat fistula or graft and or catheter placement. What was not statistically different were the rates of just tunneled catheter alone in the two groups. What they did find, however, was that adjusted mortality in the AV fistula group was slightly less than the graft group, and this was felt to be statistically significant. So looking closer at catheter dependence after access placement, this is another retrospective study looking at USRDS data this time in patients 67 years of age and older. And they looked at the first AV fistula or graft within 1 year of HD initiation between the years of 2012 and 2017. And again, the majority of patients had a fistula. Right. And here's a graft here again, AV fistula in blue, AV graft in red. And you can see that for at least in the early time period, again, here's the percentage of patients relying on catheter and the time point here, that just prior to 6 months, there was a consistently higher percentage of catheter dependence in the AV fistula group, but that changed just short of 12 months, and then out to 3 years was lower in terms of numbers. However, AV fistula placement remains significantly associated with a greater cumulative catheter dependence days. And here you can see this is 6 months, 1 year, 2 and 3 years. The numbers in the AV fistula groups were higher as well in terms of relative rates both unadjusted and adjusted, were higher in the fistula group. Now, this did decrease over time, but was still higher in the AV fistula group. Here's a study looking at all-cause mortality. Again, a retrospective cohort, USRDS data, over 15,000 patients, incident hemodialysis, older than 67 or above. And what this study did was they looked at identified pre-dialysis vascular access placement rather than first access use. So you have AV fistula numbers, graft, and catheters. And they looked at all-cause mortality. So here you have, now the reference is AV fistula in terms of compared to graft. There was not a statistical difference in the overall group, but when you looked at specific ages, and in this case, 67 to 79, there was a statistical difference in the AV fistula versus graft. Now that, interestingly, they did not see a statistical difference in the older individuals. Catheters, however, were consistently above all age groups and an entire population associated with a greater risk of mortality. However, I'm not going to go into data now, but it is an important point that I do want to make, that there is increasing data that catheters may not be the direct cause of death, that there may be other patient-related factors that contributed to death in this association. And finally, talking a little bit about frailty specifically, this is a study looking at time to functional use of fistula and grafts in a frail cohort. So again, USRDS data, hemodialysis initiation between 2012 and 2015 with a tunneled catheter, then conversion to AV fistula or graft, followed through 2018. They did use something called a claims-based frailty indicator to classify and quantify the frailty of patients into quartiles. And again, they looked at the time to functional use, and here's the distribution of accessees. And I just wanted to share here that this is some demographic data that did confirm that higher ages or older agers were associated with higher quartiles of frailty here, 1 being the lowest and 4 being the highest quartile. So more frail, older people were certainly more frail. So here's some, just gonna check time. Here's some data that they had. Now I just really want to have you pay attention. Well, here's the fistulas and the grafts. And let's focus on the solid line, which is the highest quartile, the lesser quartiles above. So in terms of time to functional use, you can see here on the fistula and the graft, the more frail cohort, and here we have percentages of graft, I believe. Yes, and in the more frail cohort, so less folks at functional use. Less of a difference really in the graft, which is interesting. But this I also think is important in terms of death before functional use. We see the opposite trend where the more frail have a higher risk of death, and that we can see in both the fistula as well as the graft cohorts. So in recognition of complications related to vascular access, the 2019 KDOQI update for vascular access recommended placement of the right access in the right patient at the right time for the right reasons. And what they began to emphasize was that patient preferences were really key, and that we should work to develop something called an ESKD life plan, which is sort of an individualized set of modalities that consider a patient's current and anticipated medical life and circumstances, all in an effort to individualize vascular access planning, and that these should be guided by principles of shared decision-making. All right. So shared decision-making, what is it and what would it look like when we approach vascular access care? So shared decision-making is care that is defined as respectful of, responsive to the individual patient preferences, needs, values, while ensuring patients are informed and engaged in the medical decision-making process. And I think we can all admit that shared decision-making, at least I can account for myself certainly, is not broadly applied when we talk about hemodialysis access planning. more commonly, we really deliver kind of this prescriptive fistula-centered recommendation with not as much attention really on individual patient preferences. And I think honestly that this approach has really been shaped by these clinical practice guidelines that have long sort of been entrenched in our mindset, as well as these financial payment models that are linked to the prevalence of AV fistulas in patients on dialysis. There was a recent qualitative study by Wu and Peters who found that most patients interviewed really disclosed minimal engagement in vascular access planning, and they really lacked a clear understanding about the different types of accesses and their consequences. So here's a framework that was developed in a review on the subject by Margaret and Wu on the subject. And so I hope it's not too small, but it really, the A being kind of our current model and B being a model that would incorporate patient preferences. We would both ideally begin with sort of reviewing about each access site, the pros, the cons, the expectations, the trade-off, and try to individualize what evidence there is on our patient characteristics. And then at least currently, then we sort of jump to practice and say, okay, this is what we're going to do. But and I speak for myself, I think what I have not been doing and what many of us have not been doing was really trying to integrate patient preference and present the option really as choices in an effort to elicit patient values, preferences, and goals, and then come to an integration of the two where we can really incorporate what evidence there is into the patient preferences for a personalized vascular access plan. So getting back to evidence, I think it's many of the reviews and experts on the topic talk about the lack of quality, at least investigational data, and the lack of randomized controlled trials. And without that evidence, we really are not in a position to say that one is really better than the other, and that it is important as a result to incorporate patient preference and goals, as opposed to by their perceived eligibility. So where are we in terms of trying to get at more quality evidence? So a tour of clinicaltrials.gov brought me first to a single center pilot study that aimed to establish the feasibility of randomizing elderly patients, in this case 65 and older, to an AV fistula or an AV graft. Now, the study is out of Wake Forest. That institution was already mentioned today, so I thought I'd just add that in. And it looks like it is completed, and they were able to randomize 23 people to graft and 21 people to AV fistula. I think their goal was to do 50 total, so pretty close. They said that data is available, but I was not able to find any published data. But their scientific premise, and it'll be interesting to see what they find, is that graft first placement likely will yield higher rates of functional access and a need for fewer postoperative procedures, and that to aid in access development, and therefore a faster transition from the tunnel dialysis catheter to active use. And that these will likely translate into higher patient rates of satisfaction. So the second is a multi-center trial based with this same group. They've expanded to a multi-center. It's currently in recruitment with a plan, I believe, through 2026. Their goal is to recruit about 262 patients, and they've actually opted to include patients 60 years and older with at least one comorbidity: cardiovascular disease, peripheral vascular disease, and diabetes. And their primary outcomes are number of catheter-free days and number of access-related infections requiring hospitalization. They have a series of other secondary outcomes, including costs, incidence of primary failure, time to successful access cannulation, and other outcomes that are more patient-centered, decision regret, grip strength, and other sort of strength assessments, I think, to sort of incorporate to this concept of frailty. All right. So in summary, how am I doing for time? Pretty good. So the dialysis population is increasingly frail and aging, and an exclusive fistula-first vascular access strategy, in my opinion, and I think supported by the literature, is not supported by our current evidence. So incorporating patient preferences and shared decision-making will help to get at you and your patients, will help to get you and your patients to the right access choice, I believe. And that stronger data that consists of randomized control trials, like we've just discussed, as well as more qualitative studies to help to better identify what really are best practices in vascular access care. So with that, I will leave you with a final thought, and this is a quote from the latest clinical practice guidelines. So attainment of the right access in the right patient at the right time for the right reasons is a more patient-centered approach to care, where population measures, such as percentages of AV fistulas created or used, or the percentage of hemodialysis catheters, may be unhelpful and counterproductive to patient-centered goals. And with that, I'd like to thank all of our RDU patients, staff, and providers. And I'm now available for questions.
Thank you, Dr. Fleet. Really nuanced discussion of complicated issues around, I think both policy and shared decision-making models can be intended to support person-centered care. One on the population, on the average population level, and one at the individual level, but can sometimes come into tension. It's a really exemplar situation that occurs in a lot of our exemplar case that occurs in a lot of different situations. But yes, questions for Dr. Fleet.
I would just say thanks so much, Maggie, for such a wonderful review. I have a lot to say, but just trying to keep it really concise. I do worry because the literature has gone both ways. There's also a lot of strong, not only associative, but details about when catheter rates were higher in terms of patient outcomes. Yes, the population's aging a little bit. Unfortunately, the population may get younger, as we've seen such high rates of mortality. With COVID, you saw those big dips in the 75 plus age, for example. Obviously, we always want to be really closely aligned with patients, and especially with our system, which I don't think is necessarily the most, when I say system, I mean this country, is necessarily the most optimal in terms of always having a patient-centered approach. So we should definitely do that. We get substantial penalties, for example, for not having rates of fistulas and catheters that maybe are where they aim for us to be. So I think there's still a lot open to think about. I hope people in this audience and others are really committed to thinking about ways to move forward, not only with research and literature, but also thinking about policy. Because we should really get supported to be able to provide this great care if we're trying to take a patient-centric approach. So thanks so much.
Thank you.
Matt?
Yeah, thanks, Maggie. Great overview. Agree with Suzanne's comments as well. And this is an important topic. I think in my own opinion is that I really love your slide about shared decision-making around this topic. I think that's extremely important. And I think one of the things that has lagged in data on vascular access and dialysis patients is things like quality of life and patient-reported outcomes, and how repeated surgeries, for example, in an older person may actually impact people's quality of life. We all have individual stories, the 80-year-old patient who has severe vascular disease, you try to get an access in, it fails, you get another one. Now they're at a brachiobasilic fistula that requires a large, 8-centimeter incision on their upper arm to transpose it, and they get postoperative edema and swelling, or a surgical site infection. And none of these are taken into account when looking at things as crude as mortality rates, for example. So I think there's room to study this. Karen Wu, who was the first author on a number of the papers that you presented, led a kidney health initiative work group that Glenda Roberts and I sat on as well, that was looking at sort of a call to action for patient-reported outcomes in vascular access to try to get at at some of these issues. But, the reality of our current environment is, as Suzanne identifies, which is that there are real payment penalties outside of the VA for catheter rates, and also public reporting on publicly available websites that take into account rates of fistulas and catheters. They also figure into things like insurance contracts and certificate of need for dialysis facility construction and stuff. So it's such a complicated issue. Appreciate you highlighting these issues.
Thanks, Matt.
I was just going to ask, maybe to finish, you've thought about this a lot in terms of the VA RDU population. Do you have a sense of what kind of metric policy threshold might work better for this population?
Well, I think, as Matt commented, I think looking at more patient-centric measures, I think, is going to be more helpful for us, as well as, perhaps in terms of looking at excluding more from our denominator and really focusing on those who patients are interested in an AV fistula and would be considered perhaps better candidates, but really trying to avoid the tendency, as Matt described, to put multiple accesses in patients, and therefore I think really contributing to quality of life measures. So I think perhaps trying to look at more exclusions if we are to retain these AV fistula goals, I think, and even maybe focusing more on catheter numbers than AV fistula, and movement from tunneled catheters to other permanent accesses. I think our surgeons are so focused on AV fistulas. I mean, I had a patient who was 96, who the plan was very functional guy, so it was appropriate to put an access in, and the plan was for a graft. But the surgeon gets in there and she sees this beautiful vein and she just couldn't help herself. She put in a fistula that never matured. Oh, anyhow. But really, accepting grafts as a reasonable option, especially in particular individuals, and helping the surgeons also to make that movement. I think that's my hope. So focusing more on catheter days in our efforts, reduce those and move to permanent access, which doesn't have to include AV fistula.
Well, thank you again. Clearly much more to be discussed.
Oh, yes.
For yours and all the presentations today, actually. So thanks again to all the presenters. Look forward to seeing many of you at the VA next week. Have a good weekend.
Thanks, everyone. Bye.